Just a bit, we are sorting out a little technical challenge. Okay, so I'm sharing with you goals and principles of asthma management. So this is a disclaimer from AstraZeneca to indicate that this presentation is not from. What are the expected outcomes from this session? So at the end of this session, it's my all of you wonderful listeners will be able to explain the main goals of asthma management. When you see or encounter an asthma patient, you should have these goals at the back of your mind. And we should all work towards achieving those. And secondly, to be able to the main principles of asthma management for the purpose of achieving these goals of asthma management. And what are these principles I'll share with you? There are 5 of them. Number 1 is the structured assessment of the asthma patient. Number 2, anti-inflammatory relief, which is quite a recent thing in asthma management. And then what we call control-based asthma management, education of asthma patients. And then the 5th one, which is not captured here, which is partnership, which is a key principle for asthma management. I'll start off with a case of a patient I attended to. This is a 37-year-old woman who had been experiencing daily episodes of shortness of breath and frequent asthma attacks, which required nebulizations. She actually had asthma 12 years prior to me seeing her, and that asthma attacks. And anytime she presented with the asthma attacks, which were quite frequent, she would get nebulized and after be prescribed a course of prednisolone. But she would go back home to her symptoms. The symptoms had become daily the past 6 months. She also realized that the prednisone gave her some relief, so occasionally she would buy some herself from a pharmacy. Another problem was that the past 6 months, she realized that she didn't get relief from her salbutamol inhaler. The salbutamol inhaler was working, but not the past 6 months. So she heard about an asthma clinic and she decided to seek help. So at the asthma clinic, she was assessed. First, her asthma control was assessed with a tool called the asthma control test, and it was found to be very poor. Asthma control test is assessed as a score of 25. 20 to 25 means well controlled. Less than 20 is poor control. In fact, if a patient scores 15 and below, it indicates very poor control. So this patient was very poor control, and I mean, definitely from her daily symptoms, that would be the case. It was during the COVID period. Normally, we would also do peak flow, but because of COVID, we avoided a peak flow. Additionally, she was found to have persistent allergic rhinitis and intermittent allergic conjunctivitis. We'll notice that this is part of the assessment of asthma patients to assess them for allergic and other comorbidities. Also, she was assessed for her her treatment. She was found to be using only salbutamol inhaler. Her inhaler technique was very poor. We normally assess inhaler technique with a tool called Inhaler Devices Assessment Tool, and is 5. She scored 3. She was once prescribed Symbicort inhaler, but she stopped using it because, according to her, when she was using it, she wouldn't taste anything in her mouth, so she thought it was a useless device, so she threw it away somewhere. So with her management, she was educated about asthma, and there's a structured way I educate patients at my clinic. She was prescribed Symbicort 164.5, 2 morning, 2 evening. She was asked to discontinue the salbutamol and rather use additional Symbicort for symptom relief, but she was cautioned that she was allowed to use the Symbicort a maximum of 12 times in a day. She was also given olopatadine eye drops for allergic conjunctivitis and fluticasone nasal spray for the allergic rhinitis. And she was educated about self-management of asthma attacks. At my clinic, you will always get an education about how to handle asthma attacks should you experience them. At her next review 2 weeks later, she was well controlled. In fact, the symptoms had almost stopped, and she has remained controlled since then. She's never had any exacerbations since then. Her inhaler technique has remained excellent, and she no longer experiences the allergic comorbidities. We stepped her down progressively. After about 3 months, we stepped her down to Symbicort 1 morning, 1 evening, and she remained well controlled for quite a while. And Symbicort as needed for symptoms. When we manage asthma a certain way. So let me start or continue by reminding us the definition of asthma and point out a key aspect of asthma definition, which should inform the way we approach the management of asthma. Asthma is defined as a heterogeneous disease characterized by chronic airway inflammation. And that is very key. The underlying problem in asthma is chronic airway inflammation. Asthma is not a systemic disease. It is an airway disease. Unlike a disease like COPD, which is a respiratory disease with systemic implications. But asthma is entirely an airway disease. And we have to note that it is chronic in nature. It is not a disease of episodes of symptoms. It is as much a chronic disease as diabetes and hypertension. And that should inform the way we go about treating it. And it is defined by a history of respiratory symptoms. All asthma symptoms are respiratory. 4 main symptoms: wheeze, shortness of breath, chest tightness, and cough. And they vary over time and in intensity. And they exhibit variable expiratory airflow limitation. Quite a long definition, and I wouldn't go into details about it, but I just want us to note the fact of chronic airway inflammation. What are the goals of asthma management? The main goals of asthma management are, goals to achieve and then things to prevent. The goals to achieve. The first goal is to control the symptoms. Asthma is not curable. We can only control it. The second goal is having a control of symptoms. The patient should have normal quality of life. That means that the patient should be able to attend school every day without any interference from asthma. They should be able to work without any interference from asthma. Last week, I saw a young man who has been attending a clinic for, and he told me that his office is, on a story building. And when he is climbing, he has to stop and take breaths before he can eventually make it to his office. That shouldn't be the case of an asthma patient. The goals continue. This is also to prevent adverse events. Two main things that should be prevented in asthma patients: acute attacks, and then worst of all, asthma deaths. As our chairperson said, we are having too many asthma deaths around the world and in our country. If I should ask you how many people die from asthma in Ghana, I'm sure your guess may not be quite right, but we lose 4 to 5 people per day from WHO data. And data shows that about 65% of asthma deaths occur before patients arrive at the hospital. So they occur on the blind side of healthcare workers. And that's why we tend not to appreciate it. But asthma kills. In the UK, they did a study to find out why asthma still kills. They lose about 3 people per day to asthma, even in the advanced setting. So it's quite a dangerous disease, and we should see it as such. Having discussed the goals of asthma management, how do we achieve these goals? And that's where the principles come in. Why do we have to talk about the principles of asthma management? If we do not know the principles of asthma management, we will manage asthma the way that leaves patients suffering daily symptoms, and some unfortunately die from it. It should be your goal that no asthma patient who sees you should continue to experience symptoms and worst of all die. The principles of asthma management optimize the management of asthma based on current evidence and recommendations. I would advise that we all update ourselves of the current trends in the evidence-based management of asthma. There's a WHO outfit called the Global Initiative for Asthma that does daily updates on asthma management, and their publications are available online. So you can just Google GINA. I mean, the short form of it is GINA, G-I-N-A. So if you Google GINA, they normally do 2 publications, the main document and the package size. I tell you, you'll struggle to exhaust reading the main document, but the package size is just about 50 pages. We can all read it and update our knowledge of asthma management. Again, the principles of asthma management maximize the chance of the best outcomes, and they minimize adverse events, asthma attacks, and then interference with normal life. And then certainly they minimize the incidence of asthma deaths. What are these principles? And these are the principles that I have implemented at my clinic these years. Principle number 1, when you encounter an asthma patient, you should go through a structured assessment. And note that the statement is structured assessment of the asthma patient rather than the structured assessment of asthma. You have to assess the asthma patient as a whole. And asthma patients tend to have the problem of asthma and also others that are related to the asthma, and some which are not quite related to the asthma. The second principle is called anti-inflammatory relief, which is quite a recent thing, which began to appear in GINA guidelines from 2019. Anti-inflammatory relief, which is abbreviated AIR or AIR. I'm sure quite a number of you are not familiar with it, but I'll explain it to you in due course. The third principle is control-based asthma management, which is how we manage asthma of the asthma patient, which is very cardinal. And the fifth, the physician-patient partnership. Every asthma patient should have a physician that he calls. Just when I was sitting down getting ready to speak, I had a call from one of my asthma, the mother of 2 children I've been seeing for asthma. So let's talk about the first one, which is structured assessment of the asthma patient. What does it mean? There's a structured way of assessing asthma patients, which ensures that all their areas of needs are picked up so that they can be addressed. And there is something that Gina recommends. Structured assessment has 3 domains. Domain number 1, assess asthma control. Domain number 2, assess treatment issues. Domain number 3, assess comorbidity. So whenever an asthma patient, you should assessment of assessment. So asthma is recommended. We assess asthma symptoms, questionnaires about their experiences, and over the past 4 weeks. The one that I use at test, which is freely available online. So it asks patient questions over the past 4 weeks, and based on their responses, you score them. The total score is 25. So this tool I found very useful. It helps me to assess my patients, to know how they are. Asthma is as much hypertension control, asthma symptom control. Assessing asthma control is more than doing peak flow. Peak flow does not assess how well the patient is controlled. Peak flow is part of asthma control assessment, but it tells you how the risk that the patient going from your consulting room will have an attack. At my clinic one day, one of my residents assessed the patient, he asked which was picked up, and she asked what does that this can be, because the definition of asthma exacerbation is worsening symptoms and or lung function. So even though her symptoms were not so bad, the people was telling us that there was the airway inflammation was worsening. So we put her on prednisolone. But in spite of that, the next couple of days, she came to the emergency room with an acute attack. So that's how useful the assessments are. Domain number 2, check treatment medication. Check the patient's medication. What medication is he or she using? So in the case I presented, I realized that we assessed the medication and realized that she was using only salbutamol, which in current recommendations is not suitable. Which scores 5 maneuvers in the use of the inhaler devices, irrespective of the device. And this patient didn't do too well. So it gives us an opportunity to which maneuvers the patient is missing, and then we get to correct it. I have a pharmacist with me who often takes care of that. Then you ask about side effects. Then asthma action plan. I've used it a couple of times. Useful. But and goals for their own asthma. Comorbidities: assess the patient for allergic rhinosynovitis, allergic conjunctivitis, atopic dermatitis. At my clinic, 69% of the patients, adult patients, have allergic rhinitis, 66% have allergic conjunctivitis, 45% have atopic dermatitis. So these conditions are really common. This like GERD, etc. Always take note of obesity among your patients because it confounds the treatment. We should bear in mind that patients do not readily associate these conditions with their asthma. So they will not readily tell you unless you inquire about them, but they affect the quality of life. Allergic rhinitis, allergic conjunctivitis, it will affect the patient's quality of life. Principle number 2, which is a big change in asthma management now, which is abbreviated AIR, anti-inflammatory response. What we should bear in mind is that asthma symptoms, that is, if a patient is experiencing symptoms underlined by worsening chronic airway inflammation or an acute on chronic airway inflammation, which results in worsening bronchoconstriction. But unfortunately, our treatment tends to focus on the bronchoconstriction. And that has been found to not. The current management of asthma symptoms is based on the principle of anti-response, which focuses on dealing with the underlying worsening inflammation, which is occasioning the symptoms. And the studies that brought this to the fore are the Sigma trials, which clearly show that when you administer medications that include corticosteroids for patient symptoms, it significantly improves symptoms. In fact, the Sigma trials show that if a patient uses inhalers which contain corticosteroids, it reduces subsequent symptoms by as much as 6-7%. Initially, I had the Sigma trials, but when I looked at the 35 minutes I've been given, I realized that if I go into the details, it will delay my time to avoid it. Now let's see how anti-inflammatory response, anti-inflammatory relief plays out in GINA guidelines. Shows GINA recommendations as at 2018. Now what I want you to pay attention to when you look at this, look at the, this is, though some of you are familiar with this table, it tells you GINA's recommendation of controller medicines and then reliever medicines. You realize that here in 2018, GINA was recommending that for the main treatment for asthma symptoms was short-acting beta agonist. GINA's recommendation as at 2018. Then in 2019, they changed it completely. So in 2019, they, in the way asthma symptoms are to be managed. And what is the statement of that change? The statement is that the treatment of asthma with short-acting bronchodilators alone is no longer recommended. So GINA no longer recommends treating adolescents and then adults with asthma with short-acting bronchodilators. They don't use bronchodilators. They say bronchodilators alone. Why? Because bronchodilators will only dilate the airway and does not tackle the main problem, which is the worsening airway inflammation. So instead, they should receive symptom-driven, that is, those with mild symptoms, corticosteroid-containing inhaler. So what GINA is saying is that if you have patients who have mild asthma doesn't have a strict definition, but presumptively, those are patients who have symptoms, just a few of them every month, daily symptoms which do not interfere with their sleep and life. So such patients need to give only salbutamol inhaler. GINA says, no way. Now give them inhalers which contain corticosteroids. So even if you have to give them salbutamol, you also have to give them a plain corticosteroid, or you should give them a combination of inhaled corticosteroid and beta 2 agonist. The key change. Now, this approach to dealing with asthma symptoms is what is called the anti-inflammatory relief, because you are treating the symptoms with treatment which contain corticosteroids as well as beta 2 agonists. So these are all details of the recommendations. I'll not go through them because of things that they realized is that salbutamol has issues. In fact, salbutamol has been found to be associated with asthma deaths if it is used too frequently, especially if a patient uses more canister per month. It's a risk factor for asthma deaths. Why is this so? You realize that in my patient, she was using salbutamol inhaler, but at a point she was not experiencing relief. So Gina gives us the reasons. Reason number one is that beta 2 agonist, there's down regulation of the beta of the airway, of the beta 2 receptors in the airway. So when you administer the beta 2 agonist, there are no receptors there, or the population of the receptors are significantly reduced. So they are not, really effective. And also, salbutamol can cause rebound hyperresponsiveness. And generally, with time, patients have decreased bronchodilator response. Salbutamol can only be effective to the extent that your underlying airway inflammation allows it. Safety, Gina no longer recommends salbutamol only treatment for any stage of asthma. Now they recommend that patients should, those who have mild symptoms or mild asthma, they should have as needed inhalers which contain inhaled corticosteroids. Those who have more frequent symptoms, they should use ICS containing inhalers daily. So another important thing is that now the recommended drug for the recommended beta 2 agonist for relief is formoterol rather than salbutamol. Why? Agonist, it dilates the airway for up to 12 hours compared to salbutamol, which does it for only 4 hours. So currently, the recommended drug in combination with inhaled corticosteroid for relief of asthma symptoms is formoterol. So we realize that in the guidelines, the preferred asthma treatment is formoterol ICS inhalers, used both as relievers and controllers. So in 2019, this is how GINA guidelines look like. Now, they recommend that for relief, there's a preferred relief, which is as needed low dose ICS formoterol. So what this means is that if a clinic, you've nebulized him, he's going home, the reliever he should be using is a drug that contains a combination of inhaled corticosteroid and formoterol. The salbutamol has now dropped as an alternative. That is, if the patient, for one reason or the other, cannot use the formoterol ICS. So this was 2019, 2021. And then in 2022, based on evidence, they recommend reliever panel and then the controller panel. But here you realize that the reliever panel is ICS formoterol. And then the controller panel is the same ICS formoterol. Then they have an alternative recommendation where the reliever is short-acting beta agonist and then other inhaled corticosteroid long-acting beta 2 agonist combinations. Rather than to give a patient medication, what this diagram is saying is that the preferred treatment, which is track 1, is that give the patient an inhaler which contains formoterol and then a long-acting beta 2 agonist. and that patient should inhale both as a reliever, not use patient an inhaler which contains a beta-2 agonist other than formoterol. So you can say something like salmeterol and fluticasone. But that's because the salmeterol is not recommended for use as a reliever. So the patient can just use it as maintenance. But if that's the experience, the result is going to you can't give a people control salbutamol inhaler patient who is given both as a controller and a reliever. But if you give a patient a drug like Bexitrol or Seretide, because they contain salmeterol ice, because no, formoterol has an early onset of action of 3 minutes, just like salbutamol. But salmeterol has an interesting profile. When you give it, it takes a while before it starts dilating the airway, so it cannot be used as a reliever. So if a patient is using salmeterol ICS, you should also prescribe salbutamol inhaler as a reliever. Principle number 3, control-based management. Your patient should always be managed to control their symptoms. I have a patient I was seeing somewhere, she was having symptoms all the time. And now, past 6 years, nobody has told me that asthma can be controlled. And when I started treating her, till today, she doesn't. Using the same device. So here, what is that is the same as the preferred treatments recommendation, where you use a formoterol ICS drug, and you ask them to use it both as a reliever and controller. So, for example, you can tell a patient, maybe the patient has few symptoms, or let's take our patient who had daily symptoms. You can tell her, oh, use your Symbicort morning then additional if you can additional, but don't more than.
Recording in progress.
Agonist drug like Seretide, which does not contain formoterol. So if you are giving Seretide, they can use the Seretide daily, but when they have symptoms, they should. Salbutamol inhaler, and then a plain corticosteroid. This is beclomethasone, one of my favorite drugs. I once called the pharmacy shop to ask whether they had. They said, Dr. Steele, you are the only person who prescribes beclomethasone. Hey, pharmacy companies keep bringing me beclomethasone, which is expiring. They are there, but we don't use them. So this would have been my presentation for children. But I think, Doctor, once my boss is here, I won't talk about that. But children must also have both salbutamol and controller. I was asking one of my residents who was seeing an asthma patient, 4 years old, who had been on admission. Now, I asked him that, so this patient you are discharging, which controller are you going to give him? And then he was stuck. He was not used to giving controller inhalers to children, but children need to be put on controller medication. So the principle number 4 is educating asthma patients. There was a study called the Global Asthma Physicians Patients Study, which showed that doctors overestimate what they think of how much they educate patients. So they asked doctors in a clinic, do you educate your patients? They said, oh yeah, we educate them. Then they asked the patients, did your doctor educate you about asthma? Did he give you information about asthma? They said, no. Your medication, did the doctor give you information about it? That this one is reliever? They said, no. So they realized that the doctors were overestimating how much they educate the patient. So educate. This patient who stopped using the Symbicort, why did she stop using it? Because she was not educated about the Symbicort. In the first place, she was just given the Symbicort without being told what it was for. She was not specifically told that this Symbicort, when you use it, when you inhale, it's supposed to get into your airway and not your mouth, so you not taste it. The patient was not educated about it. Always educate your asthma patients. How do you educate asthma patients? 3 main areas. Area number 1, give them general information about the asthma. Tell them what it is. That is a chronic disease which occasionally may give them episodes. It's not curable, it can be controlled. Education area number 2, teach them about the treatment. Which medication is reliever and controller, and how do you use them? Teach them about inhaler technique. And then education area number 3, self-management, especially of acute exacerbations. I always ask my patients, if you leave my clinic, should you have an attack, how are you going to manage it? And they are supposed to tell me that, oh, we'll use this reliever. When I have an attack, I have to use it so often, every 20 minutes until I experience relief. If it's very severe, I cannot speak. I'm so breathless, I cannot speak. I start using my reliever and then I rush to the hospital. So they should know the danger signs. Patients should always be educated about the asthma, at least in those 3 areas. The last principle is physician-patient partnership. Give your patient your numbers, have an association with them, some kind of relationship with them. It's best to do it in an asthma clinic. And you should be interested in starting asthma clinics in a way at your hospitals. It's very rewarding. You'll be surprised how many people you will help and how many people you will save from deaths. So I'll end here. And I'm sure that these principles will stick with us. Principle number 1, structured assessment of asthma. Principle number 2, anti-inflammatory relief. Principle number 3, control-based asthma management. Principle number 4, educating your patients. Principle number 5, physician-patient, and then family partnership. So thank you very much for listening. And then I'm sure we'll have a session for questions. Thank you.
Recording in progress.
Thank you very much, Dr. Dabayori. And thanks once again for the opportunity to speak at this forum. This is the second time this year. And my job today is to talk to you about the optimal therapy for patients with pediatric asthma in the new normal. And it's always good to have a brother. Steve is my brother, and he has done most of my work for me. So hopefully my work should be very easy and straight to the point. So this presentation, AstraZeneca does not advocate for the use of its products in any manner unless it is indicated or when we are prescribing it. And all the information we are giving you is based on our professional advice. So by way of my outline, this is what I will briefly want to talk about. What is asthma, the allergic response, the benefit of using corticosteroids with nebulization, share some few experience with you, and then what to do when we are doing nebulization in this new environment of COVID. And then we'll take our questions and contributions. I'm sure you've seen this definition already, so I will not say much except that I'll just emphasize on the heterogeneity of asthma. So asthma is not a single disease, so you cannot handle every asthma patient the same way. Just as Steve said, assess every patient that comes to you. Don't think that because this is asthma, every asthma, just generic prescription for everybody. It's a heterogeneous disease, but underlying these different types of conditions is a chronic airway inflammation. So in whichever type you think your patient has, know that it has chronic airway inflammation and you have to deal with it. Now, asthma presents differently. Somebody's asthma will present with cough. Somebody may not be coughing, but will just come with wheezing. Somebody will just come with tightness. So that is a physical way in which they present. Sometimes as young medical officers, we want to see a patient coming with wheezing before we think that this person is having an attack. Like I still shared the experience with you. The patient comes in and peak flow rate was very low. It tells you that this patient is on his way. He's not having symptoms, but you might have to step in. And then the endotypes talks about the different mechanisms, and there are different types of asthma. Some are allergic based and some are non-allergic based, like atopic based and other. So depending on the biological process that is going on and how that patient will also respond to the treatment that you give. So you should have all this at the back of your mind. Now, how do we diagnose asthma? Typically, it's based on the characteristic symptoms that the patients tend to have, especially in pediatrics, where the evidence of bronchoconstriction, reversibility, and variable airflow limitation is a bit difficult to assess in children. Basically, and most of the time, we tend to base our diagnosis more on the classical presentation of the recurrent episodes of their symptoms. We should always do well to document the reason why we are diagnosing one patient as asthmatic or not in the note, because we are not the ones who always sees them. And therefore, we need to make sure we document very well. Many a times I have clients coming to me and they say, I went to this clinic, they said my child has asthma. I hear you are very good in asthma, so I want to come for you to confirm whether my child has asthma or not. And then I will just smile and look at them and say, hey, do I look like a magician or something? Because normally, if the asthmatic comes to you and is not having an exacerbation, you may not find any symptom. Everything will be fine. And if you don't take care, you say, oh, your child doesn't have asthma, go. You should be careful because examination in asthma, unless they're having an exacerbation, will always be normal. Now, this is a normal airway here, and then the airway of a patient with asthma. How do we get here? I'm sure we know that most of us are not, or most asthmatics are not born with asthma. When they are born with asthma, they don't have the symptoms. You cannot diagnose it in early life until later on. So I will take a bit of time here and try to see if I'll be able to explain to you what happens in the airway of a patient. So you can see the normal airway, and then the airway of an asthmatic. When the baby is born, the baby is not asthmatic or doesn't have symptoms and all that because the patient is not sensitized. So you need the allergens or the pollens coming into the airway. And then if you remember our physiology or a few of those immunology, we have our antigen presenting cells, the dendritic cells, which are in our airway. So these antigen presenting cells engulf these allergens. They take them into the submucous layer of the airway where we have our T helper cells, the lymphocytes. They present them, that's what they are called, antigen presenting cells. So they carry the antigen, present them to the T helper cells. When they present them to the T helper cells, the T helper cells produces interleukins. You have interleukin 4 and interleukin 5. What interleukin 4 does is to cause the B cells to produce immunoglobulins, the IgEs. All right, the IgEs then gets attached to the mast cells. And some of the IgEs will migrate into the airway and also gets attached to the mast cells in the airway. The mast cells, some of them will degranulate and release interleukin 5 as well. So from the T helper cells and the mast cells also release interleukin 5, leukotrienes, and a lot of other inflammatory mediators. They end up also recruiting the eosinophils. And like we know in asthmatics, they tend to have high eosinophil levels because of the reaction, the inflammatory reaction tend to recruit more eosinophils into the airway. So these mast cells with the antibodies of the allergens produced gets attached, and now they come and line up in the airway waiting for the next attack. So this sensitization goes on over a period of time. And that is why usually you don't have younger children presenting with asthma in early ages. And the peak incidence starts from about 5 to about 9 years. That's when they tend to present, because the sensitization has to go on for some time before now the symptoms becomes what? Obvious, because it's a chronic airway inflammation. So it starts slowly developing over time before now it begins to show you the symptoms, usually by 5 to about 9 years when they present to us. So continuing with what happens in the airway, you have the allergen coming in again. The mast cells have already been activated. So once they come in, they degranulate and they release their inflammatory mediators. That causes destruction of the lining of the airway, opening the tight junctions. Some of the allergens stimulate the nerve endings in the submucous layer. And then this vagus nerve will release its acetylcholine that will cause the smooth muscle constriction, therefore narrowing the airway. So that's what causes the bronchoconstriction. When the nerve endings are stimulated, releasing the acetylcholine, causing the smooth muscle constriction. We have goblet cells that also line the airway. They are also stimulated from the inflammatory mediators to produce more mucus to come and line the airway in order to trap the pathogens and the allergens that are stimulating the airway. And so you have a lot of mucus production in the asthmatics as well. Then with the inflammatory mediators that are released from the eosinophils, cause more distraction in the airway, and you can see the cells are totally destroyed, open the tight junctions, a lot of fluids exuding into the airway, which causes further narrowing of the airway. So this is typically what goes on in the airway of an asthmatic. So over a period of time, this inflammation will keep on going on. So how do you manage this problem or this patient? You have to think of an effective rescue medication, as has been described by Dr. Adazi. And then you have to also find a way of reversing the inflammatory cascade that is ongoing, because the cascade, once it sets in, if you don't break it, it keeps on going on. And that's why it's chronic, it's ongoing. Okay. And then you have to also try to avoid the allergens, whatever is stimulating the airway inflammation. If you keep on exposing yourself to the allergens, then no matter what still does, you will still come in with what? With symptoms. So you should also always try to find out the allergens and avoid them as much as you can. And then monitoring your asthma control from your the clinic or from your subsequent reviews from the various description that has been given. So how do we optimize the management of an asthmatic? We should remember it's a heterogeneous disease. And underlying this is the chronic airway inflammation, which is a hallmark of the disease. So for you to optimally manage this patient, you need to manage the inflammation. If you do not manage the inflammation, but you just manage the symptoms, which is the bronchoconstriction, then you have not managed the patient well. It's like patient coming to you with a bacterial infection and has fever, and then you are giving antipyretics. You are not managing the patient, you are just treating the symptoms. So you need to always tackle the inflammation, and that is where you will be able to achieve your optimal management. So we should remember that bronchoconstriction is only a manifestation of the chronic inflammatory problem that the patient has. And so any management plan that you have that targets only the bronchoconstriction is inadequate. And Dr. Dazi has provided all the evidence from the general guidelines to us that now you do not manage an asthmatic with only a bronchodilator, and that you need to add the corticosteroids. So several guidelines now advocate for the use of inhaled corticosteroids, both in mild and then in the persistent asthma or uncontrolled asthma. Low dose inhaled steroids in both acute exacerbation and also as a preventer is always necessary if you are optimally going to manage your patient with asthma. This prevents structural changes that results from the chronic airway inflammation and then the airway remodeling. Because if you do not stop the inflammation or break the cycle, then continuous inflammation, inflammation when it's healing, it will lead to fibrosis and what have you. So over time, the airway becomes permanently narrowed or stiff and therefore not able to dilate. And so then this patient keeps on having persistent symptoms all day, all night. Patient is having symptoms because the airway has now remodeled, and that is what we need to prevent. So this has been said that now, even from step one, those who have just mild or intermittent asthma, they still need the low dose inhaled steroid. Or anytime you are giving it a short acting beta-2 agonist, you need to also add the inhaled corticosteroids. Why is it so? We used to think that steroids takes a long time to have their action, but it has been proven that genomic mechanism of action and then the genomic mechanism of action. So I always give this example that when we are having an anaphylactic reaction, a urticaria or what have you, and the patient comes in, what do? We give hydrocortisone, isn't it? And once you start giving it, within seconds or minutes, you start seeing relief. So if truly steroids takes forever or hours or days to have their effect, then why do we get that effect so rapidly? So from the non-genomic mechanism of action, it just acts on the membrane, and the onset of action is very rapid, within seconds to minutes. And it causes inhibition of catechol-amine disposal and also reduces the hyperperfusion that occurs in the airway. So a lot of studies have shown that using low dose inhaled corticosteroids or inhaled corticosteroid together with the short-acting beta-2 agonists have an anti-inflammatory and bronchodilatory effect, and that they work synergistically. Because as the steroids leads to protein synthesis, so stimulates receptor production for the beta-2 agonist to have its effect, whilst the steroid also slows down the inflammatory process. Because over time, like Steve said, the prolonged use of the short-acting beta-2 agonist, you start losing some of the receptors. And so when you are giving the low-dose steroid, it also helps with the synthesis of these receptors, and therefore increases the action of the bronchodilators over time. Nebulized budesonide has also been shown to effectively decrease airway inflammation. And this study showed that a single dose of nebulized budesonide rapidly decrease the respiratory nitric oxide levels within 6 hours in the airway. And nitric oxide, expired nitric oxide is one of the molecules that depicts airway inflammation. Budesonide that is also combined with tebutalin has also been shown to quickly and effectively relieve acute asthma symptoms. And high dose budesonide, which was added to the standard of care, also reduces the length of hospital stay. So previously, you were just giving the salbutamol or the short-acting beta-2 agonist, and then just maybe a patropium in nebulizing our patients. Now, when you add budesonide, it shortens the length of stay. So after 2 days, about 60% of patients who had a high-dose nebulized budesonide, which was added to the standard of care, were discharged compared to those who just had the standard of care, who had only 24% of them being discharged from the hospital. Early intervention with budesonide was also shown to protect the decline in lung function that is observed in asthmatic patients. So if you have an asthmatic patient and you don't optimally manage the patient very well, over time, the lung function decreases over time. And this showed that when you treat asthmatics early, right from diagnosis, once you diagnose them and you put them on heat corticosteroid, it prevents this decline in the lung function over time. So we need to preserve and protect their lung function early. You shouldn't wait for them to have severe symptoms before now we begin to put them on the corticosteroids. What are some of the benefits of the steroids? It has been shown that African ancestry is determined by a lot of genetic markers, and this has been associated with low lung function and also frequent exacerbations in patients with asthma. So it is better to control their asthma when you step up the heat corticosteroids than adding the long-acting beta-2 agonists. So, I mean, previously, we were managing them with the short-acting beta-2 agonists. If they are not getting better, you add the long-acting beta-2 agonists. But evidence has shown that instead of adding the long-acting beta-2 agonists, if you put them on the steroids rather, they tend to respond better. The steroid suppresses inflammation. I've said that it also inhibits cytokines and their effects in the airway, and it prevents morbidity and mortality. So Steve told us that if you use the excessive use of the beta-2 agonists is actually associated with some increase in morbidity and mortality as well. So when you use the steroids, you tend to reduce or prevent the morbidity and mortality. And it has been shown that the use of low-dose steroids decreases the risk of death from asthma. And if 4 people are dying from asthma a day in Ghana, then we need to do something to stop this from happening. Sometimes we are always scared about some of the side effects, which is oropharyngeal infections. And then systemic absorption will only occur when you give doses that are greater than 800 microgram. Now, from my experience, this is the protocol that we tend to use at our clinic when we have patients with asthma coming in, especially at the emergency. Once they come in and we establish that they are having an acute exacerbation, you commence oxygen therapy immediately. You take a brief history whilst you are assessing them, what you tend to call maybe primary survey. Whilst you are doing your primary survey, you take a quick history. You listen to the chest for air entry and any other sounds that you may hear. You need to do this quick assessment because these are the things that we are going to use in assessing whether your patient is improving or not, and you have to document it also. We start nebulizing with salbutamol, apatropine, and budesonide, and we drive the nebulization with oxygen if it is available. So instead of using just a nebulizer, if you have an oxygen source available, we use the oxygen source to drive the nebulization, and that tends to give them very good relief. You don't have to have all the 3 before you start. Whatever is available, you go ahead and then give it. Now we tend to repeat the nebulizations usually after 30 minutes, but we repeat with just salbutamol and apatropium. The budesonide is usually given 12 hourly. Unless it's very severe, then we go 8 hourly or 6 hourly, depending on our assessment. We aim to do at least about 3 nebulizations within 1 hour. If it's very severe, what we call back to back. So within 20 minutes, you repeat the nebulization. The key is in always assessing the attack. Sorry. The key in always doing reassessment, because it's not only about making the diagnosis and writing the right amount of medications to give, writing a nice plan and then just dropping it off and going. You need to come back after 15, 20 minutes, reassess this patient based on the vitals that you assessed and documented and see whether the patient is improving or not. We tend to admit all acute exacerbations at least overnight or 24 hours at the emergency room before we send them home. Because the tendency is that once they come in and you nebulize them and they get better, then they want to, children, they start jumping around, hopping around, and you want to let them go. Sometimes they will not even get to the car park and then they come back to you. Sometimes they get home, and as soon as they get home, they don't even put their bag down and then they come back. Sometimes they get home and then in the night, they will come back. Or sometimes early in the morning, they will come back. These are all categories of patients that have come back like that before. So normally we tend to keep them overnight to be sure that the exacerbation is well controlled before we let them go. Since we started doing this, we have significantly reduced the number of admissions to the ICU. And over the last 4 years, we've had only about 4 admissions to the ICU. Before then, almost every year, we have about 2 or 3 children having to go to ICU to be intubated to just manage their exacerbation. But there were a few of them that once you hear they have come, then just put your hand on your head because you know that you are going to end up at the ICU. And Dr. Michelle is here, I'm sure she can mention some of the names. But it's a long time we even saw some of them. They hardly now even come with an exacerbation. And almost all those who came within the last 4 years came in as a referral, and they came in already very bad, and we couldn't just wait. We had to take them all straight to the ICU. Now, after managing them, we follow them up at the clinic, and these are the numbers at the clinic since we started collecting data, and the number is just going up and up. The last one was just up to the 8th month of the year. That was in 2021 or 2020. It was only up to August. That is why it's down. But you can see that the numbers keep going up. So we keep having the asthmatics coming. And I'm sure we all know that the incidence of asthma, prevalence of asthma, keeps on almost doubling every decade, every 10 years. And it keeps happening. So they are with us, and we need to find them and manage them very well. When COVID came in, because of the risk of getting COVID, people were shying away from nebulization. And the reason was that nebulization was an aerosol generating procedure. And therefore, any aerosol generating procedure posed a risk of transmitting COVID. However, evidence showed that nebulization should be continued during the pandemic. And so we should not be scared to nebulize them, except that you need to put in some measures to mitigate the risk. And there are patients that are well informed and are able to even do nebulizations at home. In fact, some adults have their own nebulizers at home, and in the morning before they step out and go, they will just nebulize themselves before they step out of their homes. So we need more information or data on probably the number of COVID transmission that has happened as a result of nebulizations. I don't have any yet. Probably we need to put our heads together and see if there's anything else. So we should not shy away from nebulizations, especially with our patients with asthma, because they really need it. Nebulization with the ICS is irreplaceable in patients that need it. And a lot of times, yes, when COVID came, what we were doing was that we were encouraging the parents to use the short-acting beta-2 agonists more frequently, because evidence has also shown that if you use it more frequently, like maybe 4 puffs every 20 minutes, and then you review it maybe hourly over time, the exacerbation seems to relieve. But you know our patients, they cannot wait, because they will tell you that if you've used the salbutamol and the patient is not getting better, and that's why they've come to the hospital. You are telling them that they should still keep on using the salbutamol. They don't feel fine unless you do something. And once you nebulize them, the patient, the mother is calm, father is calm, child is also okay. So it is something that we should realize that they need it, and you need to nebulize them when they come to you. So nebulized inhaled corticosteroid is part of an optimal treatment for asthma, and I think the evidence has been duly presented here today. Asthma drug administration by nebulization has many other medical benefits as well, because like I mentioned earlier on, you can nebulize with oxygen, so you deliver oxygen at the same time as your medications, and you are not going to nebulize and finish before you come and give oxygen. So it has many other benefits. You can nebulize 2 or 3 medications at the same time as well. And it allows for high doses to also be given, because it's going directly into the airway and can be co-administered with other medications. Nebulization also allows for adjustment of the medications, and it also improves the patient compliance, because it gives them confidence that yes, you've done something different from what they have done. So management, like I've said, involves the relieving of the symptoms, the use of steroids, and then the long-acting beta-2 agonist as a preventer, and then reviewing the patient's medications and checking their compliance, and then identification and avoidance of triggers, and then regular follow-ups with their personal asthma plans, and then patient education. These principles have been well explained by Steve, so I will move on. So asthma control, optimal therapy. I mean, one of the questions you can ask briefly, within the past 4 weeks, daytime symptoms, are you having daytime symptoms more than twice per week, or any nighttime waking up because of asthma? The use of short-acting beta-2 agonists for symptoms more than twice per week, any activity limitation due to asthma. And once they respond yes to any of these, it means the asthma is not optimally controlled, and you need to do more to be able to control their asthma. So in conclusion, optimized management of asthma includes the use of ICS. And ICS is as effective as the systemic corticosteroids. It improves acute symptoms and help achieve asthma control. It reduces the length of stay in hospitals and also reduces the frequency of asthma exacerbations. And as I mentioned earlier on, the ICS also activates the rapid non-genomic actions and gives fast relief to our patients. So the advice is don't use salbutamol alone if possible. We are not saying don't use it before you go and misquote us. Don't use it alone if it is possible. You should always add an inhaled corticosteroids. Thank you very much. And we'll take your questions, comments, and contributions.
So after these 2 enlightening presentations, we've come to the question and answer session. And we do invite questions from the online participants as well as those in-house. Edward, are we ready for the online participants?
Yes, so I will take a few questions from, so we have 2 platforms, the CES platform and then those. So I will take the ones that will come in.
Okay.
Okay, so yeah, so we have three platforms: the CES platform, the AstraZeneca platform, and those of us in-house. So until we are ready with those online, those of us here, you can just show by hand. I will just pass the microphone to you, and then you ask your question. First question. Okay.
Okay.
Thank you. Hello, thank you very much. My name is Dr. Desmond Alute. I'm grateful for the very insightful presentations by both speakers. And I want to ask that, is there a proven permanent way of dealing with the atopic symptoms like allergic rhinitis and conjunctivitis? How long can your patients be on antihistamines or some of the medications you use to control? Is there a proven way of dealing with them permanently? Thank you.
So there's no name allocated. So I'll start with Alan on my right, if you would like to take this question, please.
So thank you very much for the question. It sounds like you are being bothered somewhere, or somebody you know is being bothered by these symptoms. By permanent way of dealing with it, I don't know whether you mean a cure. If you mean a cure, I'm not aware that there is any cure per se for allergic rhinitis or conjunctivitis. There is immunotherapy, which is based on the principle of exposing people to allergens with the hope of desensitizing them to the allergen with time. And it is out there in Ghana. I'm not aware that anybody does it, but there's evidence that it does work, but obviously it's associated with its own dangers and it doesn't work in everybody. So that is the closest we can come to. I'm not sure whether it permanently deals with those allergies, but the way to deal with the allergies practically is to control them. And normally the approach is to classify them as intermittent or persistent. Allergic rhinitis, for example, if it is both of them, allergic rhinitis and conjunctivitis, when they are intermittent, you can rely on the antihistamines. But when they are persistent, then you do both the antihistamines and the corticosteroids. So for allergic rhinitis, those who have intermittent symptoms, you can put them on oral antihistamines. But if it's more persistent, then you do the intranasal corticosteroid. In fact, more recently, the intermittent intranasal corticosteroids is even recommended for short-term relief of allergic rhinitis symptoms, and it's quite effective. So the most practical way of dealing with allergic rhinitis close to permanently, if there's anything, or controlling the symptoms, is to use intranasal corticosteroids. And intranasal corticosteroids is most effective when it's used for a long time. In my experience, a patient will have to be on it for about 3 months for them to really subdue the symptoms. So typically, I give my patients inhaled fluticasone. It may be in the form of Avamys or Nasonex, and they administer 2 sprays per nostrils daily for a month minimum, but it can go as long as 3 months. Normally, I inspect their nostrils. Those who have intranasal polyps I tend to recommend it longer. For allergic conjunctivitis, when it is intermittent, they can use the antihistamine eye drops. The common one is olopatadine, which comes in various forms. There is Patanol and some others. So they can drop it 2 drops 3 times daily or so for a short period of time. But when it is more persistent, then they can add the chromoglycate eye drops, sodium chromoglycate eye drops. For atopic dermatitis, is a little different. The underlying pathology is the impaired hydration of the skin. So the mainstay of treatment is hydration of the skin. So you normally advise patients to, after bathing, they don't wipe their skin dry. They just dab the skin, leave it semi-dry, and then apply emollients on them. The emollients, they don't necessarily hydrate the skin. They keep moisture on the skin. So when the skin is moist, you apply them. The one I use most often is aqueous cream. There are also soaps which are quite effective. Then when they have the flare-ups, they add on top of it the topical corticosteroids. Children normally use low potency topical corticosteroids, usually 1% hydrocortisone cream. And they should use it for up to 2 weeks or so. Sometimes they can extend it, but generally 2 weeks, it's okay. There's a publication that the main problem is that people tend to use it longer. But even that, you have to assess the skin, look at the extent of the dermatitis. Some of them have more extensive and chronic dermatitis indicated by lichenification. They tend to need the topical corticosteroids longer. Adults will do well on the same low potency corticosteroids, but when it's more advanced, you can add more higher potency corticosteroids like Elocom and those other ones. So I think with that, we can control most of them. Thank you.
Okay, so I hope you got something, but you were on the same page as me, because I was thinking about how your patients react when you tell them categorically that asthma is not curable. I've seen quite a number of reactions, and it looks like you've put a curse on them when you tell them that asthma is not curable. What are your reactions?
That's a very good question. And in fact, patients don't like hearing that. They wish they would be told that asthma is curable. And indeed, there is evidence that some people undergo remission. So the word is remission rather than cure. Some people stay in remission for quite a long time and never really get recurrence of the symptoms. But for quite a number of them, the symptoms at a point begin to rear up their head. So, well, the fact that it's not curable is not debatable. So we need to give that hard fact to the patient, but definitely it's not pleasant news. And we have to educate them to appreciate that even when they are not experiencing symptoms, the disease is very much there. In fact, Dr. Pabi talked about airway remodeling. It's been shown that airway remodeling can occur in asymptomatic patients. And a time comes that the disease starts getting out of hand and becomes difficult to control. So asthma, even when it seems to be in remission, is not definitely cured. Thank you.
Okay, any more questions in-house? Yes. And do we have some online? Okay, so after this, we'll take the online. Yeah.
Good evening, and thank you so much for this lovely presentation. My concern is on the prolonged use of steroids, because we all know that steroids have their side effects, especially for growing children. We are worried about the easy way they fracture their bones when they get the side effects and the development of gynecomastia. So what do you think we can do to limit some of these? Because if you are going to put somebody on corticosteroids for about 3 months, then you should be thinking about some of these things too. So what's your take on this? Thank you.
Thank you very much. So I showed a few of the side effects that you should not be so worried about, because that's one of the reasons why most people, when you tell parents, then they begin to be a bit worried. But like Steve said, even with the adult patient, when he realized that prednisolone helps, he himself will go to the pharmacy and go and buy it because he was getting some relief. Now, because of the dose that we give, it's low dose, normally very low dose, compared to prednisolone. We are giving maybe 1 milligram per kg for a child, so maybe you have to give 20 milligram daily for 3 days, 4 days. If you compare to maybe budesonide, we are using 250 microgram, maximum be 500 microgram, 12 hourly. So it's in micrograms. Okay, and systemic absorption is not because you are giving it directly into the airway. So systemic absorption is very minimal. So, and then also when you give it for 4 to 6 months and the patient is controlled, you step down. Like Steve said, for his patient, instead of using it twice a day, now use it once a day. So you tend to step down once you are able to achieve control. So it's not the same dose for the rest of your life. You keep stepping down, and sometimes you even do alternative daily. Sometimes we even take you off for some time. If maybe after a year or two, you've not had any symptoms and what have you, we tend to take you off. So the side effect is very minimal when it comes to the inhaled corticosteroids. And there's an evidence that it has a potential of even reducing, even when you use systemic steroids, reducing the potential height. You mentioned growth in children, potential height by about 0.5 centimeters. And one of the things that I always say is that I'll prefer for my height to reduce by 1.5 centimeters than to have persistent, maybe nighttime symptoms. I'm not able to sleep, because the disease itself, if you don't control it, can also have effect on your growth. And so you have to look at the quality of life of the patient, your ability to perform your daily activities and what have you. And I think that is fine. Maybe once I have the mic, a bit about the permanent way of dealing with the allergic rhinitis. It's an allergic problem. And I always say, if you are allergic to something, once you avoid it, then you are not likely to have the symptoms. So one of the key things is also try to find out what are the things that probably is precipitating my symptoms. And once you're able to identify some of them, I always tell parents that you may not be able to identify everything you are allergic to. So some of them are quick. Can you write an allergic test for me to go and do? I tell them it's very expensive. You'll be able to pick up 1 or 2 things that you are allergic to, but that will not be the end of your problem. You will still have symptoms. So just try and find out the things that you think you may be allergic to, and also avoid them as much as you can. And then when you have the symptoms, then you control them with the medications. So cure, no, but control or management, yes, you can comfortably manage it very well. Thank you.
So Edward, are we ready for the online?
So the first one here is from Nika Prince. He says, in the treatment of asthma, do we now switch to formoterol rather than salbutamol? That's what he sent. Please, did you get the question?
That? So I guess he's talking about using formoterol as a single drug. In fact, the use of there are trials going on to compare the use of formoterol and salbutamol for acute exacerbation, but so far none of them has made its way into the recommendation. So there is no recommendation that formoterol as a molecule should be used preferably for acute exacerbations of asthma. And formoterol as a single drug is also not recommended. So you will not see formoterol as an inhaler on the market, and it's something that is not recommended. The use of formoterol is in combination with long-acting beta-2 agonists. So you find them in those inhalers. In Ghana, we have formoterol, we have Symbicort, when you go to other jurisdictions, they have Foster, which is formoterol beclomethasone. They also have Symbicort and others. Some of my patients who get their drugs from outside bring very interesting combinations. So that's the form in which formoterol is recommended to be used. And we also have to bear in mind, we talked about anti-inflammatory relief. So using formoterol as a single drug goes against the grain of anti-inflammatory relief. So in that regard, I don't think it will ever find its way into recommendations. Thank you.
Dr. Pabi, would you want to add something? You are all right. Oh, okay. Another online question, please.
Yeah, so there's another one here. It says, what do you suggest is done to help a patient who can only afford salbutamol and not the SABA ICS?
Dr. Pabi, would you like to?
Well, so for such a patient, probably, I think, like Steve said, will need a lot of education. We need to sit this patient down and educate the patient on the need to get the SABA and then the ICS together. Because if you are giving only the salbutamol, you are not helping the patient that much. And the patient will end up coming in more exacerbation, and you end up even buying more of the SABA, which ultimately will come to the same thing. So I think what you need to do is to educate the patient more, explain the principles of the management very well, the reasons why the patient will have to be on the SABA ICS and not only the SABA alone.
And I would also like to add that evidence does show that frequent use of SABA alone increases your risk for mortality. So you need to let them understand these hard facts, as Dr. Stildazi said, they are hard facts. And together, I think you would need to help her find a way to get this inhaled corticosteroid. Yeah.
And as a matter of fact, formoterol ICS is on national health insurance. So patients don't have to buy out of the packet. All my patients, almost all of them are on insurance. So they get the formoterol ICS on it. The SABA rather, somehow they don't get it. So in our jurisdiction, cost is really not an issue. And added to that, as Dr. Pabi said, poorly controlled asthma is expensive because you keep buying the medication. If you use formoterol ICS, it's rather cost saving in the long term. Thank you.
Do we have any question in-house? Yes. Yeah.
Okay, there's a question in-house.
Yes, in-house.
Okay, then we just continue.
Hi, good evening. I'm Dr. Michelle Akondo. Thank you very much, speakers. Okay, so my concern is that we have, for our clinic at 37, we do combine the SABA and then the inhaled corticosteroids. But then we have a lot of children who have exercise-induced asthma. And usually we tell them that even though they're on the SABA and then the inhaled corticosteroids, when they get the attacks after sports or physical education or activity, we tell them to take the SABA. But now we're talking about the MAT. So what I want to understand, are we saying that when they get these attacks, they should use the combined, the SABA and in the cuts, for example? Is that what we're saying? And then that's one. And then another question is for the younger children, especially those who can't use the Symbicort. We usually prescribe the fluticasone and then the beclomethasone. But now we've realized that the beclomethasone, I don't know how you are getting it, but we don't seem to get it. And then we tell the patient to go and get it and they can't, they look all over and they don't find it. And the medications now are so expensive. I don't know. Thank you.
Dr. Pabi.
So, like you rightly said, for the children, you realize that some of them, because of their age, probably they are not even on the Symbicort and all that. So for those ones, yes, you may still have to use the SABA. Now the trick is for them to use the SABA before they go and exercise. So maybe 2 hours before they go and exercise, and then soon after they come back, then you do another maybe 2 puffs. Because if they don't do it before they go and exercise, they will go and come back with the attack. And now you have to give more doses to try and control it. So you have to take it before they go and exercise. And then when they come also, you don't wait for the attack to come. And then that way you don't tend to overly use the SABA. But for those who are on the Symbicort, yes, you can let them use just the Symbicort as a reliever also, and not more of the SABA.
Any addition?
No, I think I would add to, I'll talk about the availability of beclomethasone. Well, I'm a bit surprised because beclomethasone is very much available as far as I'm concerned. I have some pharmacies around my facility that have it, and they usually expire on them, actually. So it's very much available. What I noticed is that there is a brand in the market which is very expensive. It's about 300 Ghana cedis. One of the hospitals I work in, they had that brand. I told them I would never prescribe it, so they should take it out to the pharmacy. There's what I use is about 50 Ghana cedis. So it's quite available. Maybe you can talk to me after. I'll show you where they can get it.
He says everybody would be, but I think this is difficult. So I think rather they should contact you. Otherwise, we'll be seen as advertising a shop. Yeah. So I think we have ethical issues here. Yes. So do we have online? Yes.
Okay, so there's one question which is similar on 2 platforms. It says, what's the current teaching on managing status asthmaticus, which is similar to, is there any new guideline for managing status asthmaticus?
Well, I don't think that there's any new guidelines per se. But like I said earlier on, the key is in your monitoring of the patient. So patient comes in and then you start your nebulizations with oxygen. You do it back to back. But in other jurisdictions, what I've seen, they call it power nebulizations. They will give you all the 3 doses that is recommended is to be given to you within 1 hour at a go. So instead of maybe if it's 2.5 salbutamol for a child or 5 milligram salbutamol, they tend to use albuterol because it's very short acting. So they put all the 3 doses together and nebulize you continuously with it. And after that, you are likely to get a relief. Now, if you don't, that is if you are using only the SABA. Like I said, what we tend to do is to do a combination of the salbutamol, hypertropium, and then the budesonide. We do so because of the principles underlying the inflammatory response, the bronchoconstriction, the inflammation, and then the fluid exudation into the airway. So when you do these 3 combinations, we are doing a 3-pronged approach, and that tends to give you a lot of relief. And that is how come most of our asthmatics don't end up at the ICU like previously they tend to. So the key is your monitoring. Once you continue nebulizing them with just the standard of care medications and then add your inhaled corticosteroids, they tend to improve. Most of them tend to improve. Those who do not improve and you think may be at risk of severe morbidity or death, we tend to send them to the ICU. Then they are sort of paralyzed and then put on the nebulizer, and then we continue with the same medications until the exacerbation, because you don't want them to get overly tired, exhausted, where probably their hearts also even begin to fail and a few other challenges. So you tend to put them to sleep and then continue with your nebulizations till the lung recovers, and then you wake them up and they are fine. And basically that's what you do. There are other medications that, yes, you can also give. Magnesium sulfate is there. Sometimes we can even add adrenaline, and then also other jurisdictions will even recommend IV salbutamol. And it is not the same salbutamol you use for nebulization that is used. So please don't go and use that. It's a different type. We didn't mention all those things because hardly do you get there. Usually by the time you have to do that, you have to be in the ICU setting. So basically, I think that is what you need. The key is to monitor, review, constant review. You just don't nebulize and go and sleep and come back after 1 hour, 2 hours. By the time you come back, the patient is worse off. So back-to-back nebulizations, at least 3 nebulizations within 1 hour. And then you review. If it's still not improving, start making arrangements to an ICU or to a center where there's an expert to be able to handle it.
So, Dr. Stildazi, do you see status asthmaticus?
I've seen a few of them. In fact, there's one that we lost at my clinic. We did everything. Gave max sulfate and then adrenaline. But I think that at the time we decided to escalate to an ICU, unfortunately, she deteriorated and we lost her. We see a few of them, and the management is just as Dr. Pabi has said. But one of the ways to predict a patient who will go into that state is to categorize patients in acute asthma. So when they come, you have to categorize them according to the severity. And there are 3 categories. The first category is mild, moderate. Second category is severe. And then third category is life-threatening. Mild, moderate, they can speak. Oxygen saturation may be normal. And pulse rate may be about less than 120, respiratory rate less than 30. But when they have worse than that, oxygen saturation less than 94, pulse rates more than 120, respiratory rate over 30. That's telling you that the patient is in trouble, and you should be preparing to escalate the management, depending on the facility you are. The worst of asthma exacerbations is when they're in life-threatening state. Life-threatening asthma is defined by carbon dioxide retention. And carbon dioxide retention clinically will manifest as altered sensorium, because we know carbon dioxide retention affects cerebral processes. So if you have a patient with acute asthma and they have altered mental state, it tells you that they may be having life-threatening asthma. And life-threatening asthma, they are more likely they are more likely to result in status asthmaticus. So you start your treatment and you should be preparing to escalate to a center, a higher center. Thank you.
More questions?
So from anonymous attendee, it says, please, can you combine inhaled budesonide and IV hydrocortisone or tab prednisolone? That's what the question says.
Yes, you can. So normally those we nebulize with the budesonide, we give them the oral prednisolone as well. Like I said, the dose is usually very small. So, and for those who are on the inhaled corticosteroids already as a preventer, when they come in with an attack, you can actually increase the dose that you use for the acute exacerbation. Because they are already on it and they are still having an attack, you increase the dose a bit and give it. So yes, you can combine the two and give to your patient who has come in an exacerbation.
Please, do you withhold the inhaled budesonide in acute exacerbation, which is mild or moderate? Is it for only severe exacerbations, or can it be given in mild cases?
Yeah, I think we have said that once you diagnose a patient with asthma, that patient will have to be on an inhaled corticosteroid or a corticosteroid to try and control the inflammation. So yes, everybody will have to be on it. I think that for very little ones, the children, they tend to say that sometimes you can just hold on, but anytime they come in with an exacerbation, you should always add the inhaled corticosteroid. So as and when needed, or anytime you are using the SABA for an acute exacerbation, always combine it with a low dose inhaled corticosteroid, especially those who are less than 5. So yes, almost everybody diagnosed with asthma should be on the low dose inhaled corticosteroids. Now, once the person comes in, if he's already on an inhaled corticosteroid, he comes in, like I said, whatever you are using to nebulize, you tend to increase the dose a little bit in order to get the effect that you have. And as soon as you finish with the acute exacerbation, they go back to their normal inhaled dose corticosteroids. Of course, if they are coming in with frequent exacerbations, then it means that whatever you are giving them is not achieving the control that you need. And then you have to up the dose of the inhaled corticosteroids that you are already giving them.
Can we take, see if there are any? Okay, so we are still thinking about it. Where? Okay.
So I think I'm not sure whether the person asking the question wanted to know about nebulized budesonide in acute exacerbation and whether it has a place in mild, moderate exacerbations. In fact, there is no specific recommendation on that. So we can very much depend on our discretion. But certainly, if a patient has an acute exacerbation and you classify it as severe life-threatening, you definitely will have to, the person will benefit from nebulized budesonide. Mild, moderate, there's nothing prevents us from giving a nebulized budesonide. I find it very useful, just as Dr. Pabi does. So, and as he said, it has a lot of benefits actually.
So whilst in-house, we are still thinking, can we take some more?
Do we have one? Yeah. Okay.
Yeah. Hello.
You can go ahead.
Thank you for the opportunity. Please, in status asthmaticus, I want to know: is there still a place for theophylline and the rest? And is there an algorithm to follow when you have a case of status asthmaticus? And how many doses of what was the number of maximum doses of IV hydrocortisone 200 milligram can you give in an adult in 24 hours? If after giving nebulizing with salbutamol, giving adrenaline, giving theophylline, still the patient is not recovering, and then facilitation to an ICU too is taking more time, and the patient is with you, what can you do?
Okay, thank you. I'll take the first part of the question. Since you mentioned adults, I will defer to Steve to handle the hydrocortisone aspect. Now with aminophylline, currently it's not something that is so recommended in the management of asthma because it has a very narrow therapeutic window. And if you are giving it, you are supposed to monitor the patient, the heart, because of the narrow therapeutic window that it has. So it is not something that we normally do. But I can share my personal experience with you. In the last few months, I have had to personally use it because I had a case that I thought should go to the ICU. ICU was not available. In other words, it was full. And I couldn't get anywhere to send the patient deep in the night. And so I had to sit by the patient and give it myself and monitor and see So with strict monitoring, yes, you can give it. I'm sure a lot of us, probably the older ones among us, might have used it several times in our younger days, and we didn't get any problem. So we don't see why we should not. But now there are very safe ways of managing them. So it's not something that is readily recommended. But when you are pushed to the wall and you have no other option, yes, like I keep mentioning, for me, in managing every emergency, the key is re-evaluation. Whatever treatment you are giving, you need to be monitoring. Don't just write the instructions and turn your back. You will come back and find a different result. So you sit by the patient and then monitor the patient yourself. That way, you will be able to overcome whatever challenge you are having. Steve.
Okay.
The issue of aminophylline is a very good question. And as Dr. Pabi said, aminophylline doesn't have much credit in literature. But I mean, for the reasons that he said, apart from that, the bioavailability is also unpredictable. You give it and you can't be sure how much of it will go to the airway. So it's quite an unreliable drug. But, you know, we can't also discard our individual experiences. Another side of the evidence is that it's also not shown to add benefits for a patient who has been given nebulized salbutamol. But we can't throw away individual experiences when we are hard pressed. One situation that I would probably suggest aminophylline is when you have a patient who has ventilatory impairment. So you have a patient in asthma attack and it's so bad that the chest is silent. If you are going to give your nebulized salbutamol, the patient may not be able to effectively inhale. So in that situation, you can't give the IV aminophylline, observing all the precautions and hope that the IV aminophylline will kick mechanical activity, will improve the breathing, and then you can more effectively deliver your nebulized medication. So in that regard, in fact, I'm part of a group developing a guideline. And when it came to aminophylline, we looked at the evidence and we made that statement as part of our recommendation that in situations where the ventilation of the patient, the chest movement, chest is silent, you can't give IV aminophylline. For status asthmaticus, we have to bear in mind that the protocol is to give the nebulizations every 20 minutes until the patient improves. If after the fourth one, the patient that is not satisfactorily improved, then you have to rely on the alternatives Dr. Pabi mentions. In my personal experience, I give IV max sulfate. The recommended dose is 1.2 to 2 grams. You give it very slowly over 20 minutes. Then I have found it useful, but it's not necessarily a savior. Thank you. Yes, hydrocortisone. There's no maximum, you know, the hydrocortisone has a schedule, so you can do 100 to 400 milligrams 6 hourly. And you don't necessarily you will not get any benefit exceeding those doses. But current evidence on hydrocortisone and prednisolone is that prednisolone is just as effective as IV hydrocortisone. So unless for some reason a patient cannot take prednisolone orally, you do not have to give IV hydrocortisone. So for asthma patients, within 1 hour, you should start them on oral prednisolone. For adults, you give 1 milligrams per kg daily, 5 to 7 days, maximum 50 milligrams. And you don't need to taper down the dose if the patient has taken it for less than 2 weeks. So that habit of doing 30 milligrams, 25 milligrams, 20 is not really recommended. For children, they do 1 to 2 milligrams daily for 3 to 5 days. Maximum dose 40 milligrams. So we should bear that in mind. Thank you.
So we crave your indulgence. Sorry? Adrenaline. Oh, as a follow-up, can adrenaline be used? Yeah.
In status asthmaticus, in fact, in the guidelines, adrenaline is recommended for use in patients in anaphylaxis. But there is some recommendation that you can give IV adrenaline in status asthmaticus. In the case I just talked about, I was so hot, I had to give IV adrenaline. In fact, I went to buy the adrenaline with my own money. It didn't work, but at least it is out there. I haven't seen evidence that adrenaline per se works in status asthmaticus, but for anaphylaxis, asthma attack as part of anaphylactic reaction, adrenaline is very much the mainstay of treatment, actually.
So we'll just take our concluding online questions. So, Edward.
So it says here that what's the difference between reactive airway disease and asthma? And then I think the last two questions would be, please, where the child's pulse is extremely high, do you only do hypertropium? And the last one has to do with what will be the best approach to dealing with parents who do not accept the diagnosis of asthma and even refuse the daily ICS use for control with the excuse that the disease will be stuck on the child. So basically that is the concluding questions that we have online.
Okay, so reactive airway disease and asthma, what the difference? So in children, commonly we tend to say reactive airway disease when the diagnosis of asthma has not been established. Like I said, in children, of course, the person may come with the first attack, and that is the first time the patient is presenting. You are not sure whether it's just due to a viral illness or a viral wheeze or what have you. So most people will tend to use the reactive airway disease. And like you said, some also tend to use the reactive airway disease to pacify the parent, because once they don't want to say it may be asthma, and then the parent will not even come to you again. So, so they tend to say airway disease. Once it is established that it is asthma, then you no longer will use the term airway disease. So reactive airway disease, maybe somebody has come with the first episode, second episode of an acute wheezing episode, and we are not too sure exactly what it is, and you haven't confirmed that this is asthma. Yes, you can say reactive airway disease. In fact, somebody even also mentioned that is, I think the Americans who tend to use that to describe asthma, as because people are trying to shy away from the term because of the stigma that may be associated with this. So some tend to use the reactive airway disease in place of asthma. So the parent, like the third question, this parent will not say Tofiakwa, it's not asthma. But if it's reactive airway disease, probably it may be more acceptable to such a parent. If I come across such a parent who is refusing to accept the diagnosis, I always tell them that, look, I always prefer to be a prophet of doom. Say your child has asthma, for you to go and never have an attack again and say that I'm a fake doctor, than to try and say that, oh, it's not asthma, and then for you to go and the child to keep on getting the attacks. I describe the attack to them as somebody trying to strangle you, like somebody's holding your neck and you cannot breathe. It is not something to play with. It is not something to joke with or to say, to just wish it away. So if I were you, I would do all I can for it not to happen again than for it to happen every now and then, because you never know what will happen the next time you get an attack. I lost a nephew to asthma, I think 8 days to his 8th birthday. This is somebody, we knew he was asthmatic, parents were very regular, everything. And he was, I mean, it hit me very, I was at the postmortem and it was nothing else but asthma. I mean, as soon as the chest was open, the lungs just popped out just like that. like a balloon balloon. So I said that, look, you can wish it away, but if it is, it can be dangerous. So like we've kept saying, patient education is very, very key. You need to tell them the hard facts. Now, look, I wish that it is not. And if it is not, I'm happy. You're also happy. In the meantime, let's all do what we can, our possible best, so that he doesn't keep getting the attack, rather than wishing it away and then it's happening. So education, and taking your time to talk to them will usually do the trick. Yes, so when we are nebulizing with salbutamol and the pulse rate is very high, yes, we tend to withhold the salbutamol and then maybe just use the hypertropium and the budesonide. And once your pulse rate begins to come down, then you can go back to your salbutamol. You should remember that the attack itself can also increase your heart rate. And so, for example, if a patient comes in, maybe the heart rate is about 140 beats per minute. I'm talking about children here, not adults. If it's adults, 140, you start running away. But 140 beats per minute. And then you nebulize your salbutamol first one. It may go to, the heart rate may go to 150. I will not be so scared. But once it crosses 160, going to 180 thereabout, then I'll be very scared. And then I would hold the salbutamol until the heart rate comes down. So yes, high pulse, I would hold salbutamol and just use the hypertropium and then the corticosteroids until I am very certain that I can come back to it. Thank you.
So we've had a very, very interesting Q&A session, and education was what ended our discussion. So for each presenter, very briefly, how does patient education affect the duration of your clinic? What strategies do you use so that you are able to educate them in depth and find enough time for the rest of the patients that you have? Okay, so very briefly, and then Dr. Stilder.
Okay, so this is very difficult in our very busy clinic. So for 37 pediatrics, what we have done is we have a WhatsApp platform for all the parents that we manage in our clinic. And we allow them to ask their questions there. And then every now and then we answer them and then give them education on the platform. Sometimes some of them will call us individually. And then like Dr. Edazi said, give them your numbers. Let them be able to call you. So Dr. Michelle is almost always on the platform answering all the, I always sit back and allow her to answer all the questions. So they call us, we talk to them every now and then. Once they put a message on the platform, we respond to them. Sometimes we ask them to call us directly once we think it's urgent, and then we deal with them. So at the clinic itself, it's a bit difficult. On Thursdays when we come there, we are running a sickle cell clinic also, and it's so busy and chaotic. So it's difficult to do it in the clinic. So we have the WhatsApp platform that we use. But when the need be at the clinic, yes, we take them aside and then probably educate them as the clinic is going on. So most of the education, we tend to do it on the WhatsApp platform.
That's very innovative. Well done, 37.
Thank you. So I work with the pharmacists that I've trained. So before I arrive at the clinic, the pharmacist would normally educate the patients together. She also assesses their inhaler techniques individually. So normally when I start the clinic, I'll ask her, what's the person's IDAT score, 3/5, and then where were the lapses? So the lapses are that she couldn't hold the person didn't hold her breath for up to 10 seconds. So then we know where to educate the patient. But even apart from the education that the pharmacist does, now let me also add that in the past, from when I started my clinic, I had an asthma educator, somebody who has a PhD in asthma education. But now she's a lecturer in the university, so she's no longer available at my clinic. Then I trained nurses, but they were all ladies, they got pregnant and left me. Now I have a pharmacist. The pharmacist does a fantastic job. She's so passionate about it. Even when she's not on duty, she will avail herself for the clinic. But apart from that, I spend time myself with every patient. And depending on where the patient is, new patients will usually take more time. And those who are old, take less time, but I'll educate them in a structured manner. So that is it. But I think that managing asthma takes time. And with time, if you do the right thing, the patients will get used to the fact that this doctor takes time. So when we are coming to the clinic, we have to be prepared to spend some time.
So thank you both for sharing your strategies. I hope we can pick bits and pieces from both of these strategies to help enhance asthma education with our patients. So I'll bring this Q&A session to an end. Thank you very much. And we'll call on AstraZeneca to give us their presentation. Okay.
You can go. The presentation will be very brief, less than 5 minutes. We've had all the education that we need concerning current management of asthma. And sometimes it's quite interesting that we get all the science behind the practice. And it's quite unfortunate that we don't get to actually know if indeed all the agents that we get to see, if it's available on our markets. I want to share. Okay, so I think our two speakers have shared so much when it comes to the studies that we saw in the slides. So when it comes to budesonide, in terms of Nebulis, what I would like to share briefly, that's quite available. In the past, most of us struggle to find budesonide in terms of Nebulis. Now, wherever you find yourself, both pharmacy, both hospitals, you readily find it at 0.25 in 2 mil and 0.5 in 2 mil as well in Nebulis at most facilities. So notably, what I'd want us to note when it comes to budesonide Nebulis is that it has a very rapid absorption rate. That makes it readily available in the airway when it is administered via the airway routes through nebulization. That is why when it is combined with salbutamol, it gives it a good, therapeutic effect, as opposed to you having to go through the IV routes when it comes to managing patients in the acute setting. And within the very first 30 minutes, you have a very strong pulmonary vasoconstrictive effect. So in comparison with all the notable inhaled corticosteroid that we have, beclomethasone and even fluticasone, it has been shown to give a rapid absorption rate, which is far, far better as compared to all the ones that you've seen. So looking at the initial dosing, even right from age 6 months, Pulmicort can be given as 0.25 to 0.5 once a day, and it can be increased to 1 milligram. In the GINA guidelines, there's a section that talks about managing asthma in the acute setting, which talks about consideration of ICS in terms of higher dose. What this means is that if you start at the initial dose, you can give till you get to the high dose, as you can see here. So if you are even starting at an initial dose from 0.25 for a child, you can go as high as 1 milligram for the child. And for adults, you can start as 1 to 2 milligram. And for maintenance doses, for children, you can go as high as 2 milligram. And for adults, you can go as high as 4 milligram. It's similar to this particular slide that I've shared here. So what I wanted to take away from this particular slide is that budesonide, as we've seen in all the studies that Dr. Pabi shared, is readily available as Pulmicort nebules. And like I shared, because of its rapid absorption rate, it gives it a very good onset of action when it comes to its effects. And if you've had the chance to use Pulmicort, I mean, there's good evidence that suggests that at least with what do you call it, repeated hospitalization, we've seen up to about 45% reduction rates. And also there's a lot of studies that we could share if we tend to have a separate meeting that we just tend to focus only on studies when it comes to Pulmicort and its use when it comes to acute exacerbation. So basically, if you are managing patients in the acute phase, definitely when the patients are stable, they would need to be managed when it comes to symptoms control, when they are going home or when they are going about their day-to-day activities. And that is why you have two options available for your patients. It's either you are putting your patients on a separate reliever and a separate controller. But the question here is, how many patients will be able to comply to having one device as control and having one device as relief? So if the patient has a convenient approach of having one device, giving them two options, I believe they can also look at what Symbicort also offers them, because it gives them that 1 to 3 minutes onset when it comes to the formoterol that is combined with the budesonide again, which has that onset when it comes to its rapid resolution rates. And if patients are using Symbicort as their relief, it means that they are getting additional inflammatory protection as compared to that of salbutamol. That is what it simply means. If a patient uses Symbicort as rescue and as maintenance, the good thing about Symbicort being used as rescue and then maintenance. So basically, in the acute phase, you have Pulmicort. When the patient is stable and they are going home, you have a good option with Symbicort 84.5 for pediatric, 6 years and above, and then 164.5 for pediatric. So, ladies and gentlemen, I want to thank you so much for taking time to spend time with us. And I will hand over to the sales manager for the respiratory team to have a brief closing remark before we depart and have our dinner, and then we say a goodbye to everyone here. Thank you very much. So Elvis, if you're here, please take over and then have a closing remark.
Okay, thank you so much. I want to thank first our greetings from AstraZeneca Global. We want to use the opportunity to thank our speakers for making this event a success. We at AstraZeneca has pledged that we will go the extra mile to ensure that when it comes to asthma, when it comes to research, education, we'll do everything and providing the resources to ensure that we can mitigate and prevent or treat asthma going forward will be a key. So that is why we did Pumua. So with Pumua, I believe that by now each and every one of us know about Pumua, where we've proven that we've given a lot of nebulizers. I think we've done over 300 nebulizers since last year, where we visited almost all the district hospitals in Ghana. I myself have visited almost all the district hospitals in Ghana to ensure that we have nebulization stations and others there to ensure that the treatment of asthma is well maximized. And we didn't just stop there, because we believe in also access of the medicines. So we went the extra mile to ensure that Symbicort will also be price driven to the extent that NHIS can now cover for Symbicort. So one of the big good news is that we have Symbicort in the NHIS, which when prescribed, patient can get it for free. And we've not ended it. We are pushing to see if we can get Pulmicort 2 on the list
to ensure that we have a complete, so somebody comes in an acute phase, then he gets it for free. And when he's leaving also, he gets Symbicort 2 for free. And that is the extent. You know, though the economic challenges quite hitting all on us, we believe that we will still stand tall in delivering that to ensure that we have the product accessible for every patient with asthma. So I think we are also working effectively with GTS to ensure the establishment of the guidelines, the Ghana National Asthma Guidelines. And we are doing our possible best to ensure that we will possibly launch it and do a good work on that, so that at any point in time, we prescribers, HCPs, nurses, everybody know the protocols, make it quite easier for us to follow to treat, because it's very sad for someone to die from asthma. And it's one of the painful that one can experience. So without much I say or do, I want to once again, thank you all for coming, especially those in here and those online too. We are most grateful for always coming in or joining us in doing these meetings. I want to also say a big thank you to Team AstraZeneca for making this also successful, and the chairman for today's event, Dr. Adebayo, the two speakers, Dr. Sildazi and Dr. Pabi. We are most grateful as such, and we want to say thank you. I think from here, we will have dinner that will be served after. Just when you go out, you turn left, that'll be dinner. So they will serve you with a ticket for you to have the dinner here. And then quite unfortunate for those online. So please, maybe we'll do virtual dinner, right? Okay. So thank you so much.
Thank you too to CES for streaming to assist AstraZeneca in this meeting as well. So thank you so much. Until next time, it's goodbye from us.
you.